This is Blood and Cancer, the official podcast of MDH Hematology Oncology. I am the voice of MDH Podcasts, Nick Andrews. And I'm joined this week, as I always am, by Dr. David Henry. Dr. Henry, welcome to episode 69 of Blood and Cancer, the official podcast of MDH. You are the editor-in-chief of MDH Hematology Oncology and the host of the show. So just always checking in how we're doing with COVID. Spring has sprung. It kind of feels as if this first week of May in 2020 is the week that the Western Hemisphere kind of collectively decided that the quarantine is getting to be a bit much. So how are you doing, and how is your practice?
You know, I see the same thing happening, and I'm feeling it. It was a nice weekend. We wanted to go outside, and you kind of all of a sudden forget and think, oh, it's springtime, and uh-oh, what's on my mind? Oh, it's COVID, I have to be careful. But I'm afraid that theme is happening across the country, either get back to work or get outside, and people are frustrated and tired. And sadly, I've had some talks with colleagues that, this is not going to go away.
Yeah.
There's no cure on the horizon. Incredible science and technology is working very hard, but we'll probably be doing some kind of care, social distancing, mass hand washing, testing for some time to come. Although I think the bright light, and then we'll move on, is there'll be much more testing available, whether you're carrier, infected, or seropositive, and what's that mean. So I'm really hoping that will save the day.
And of course, the FDA just approved emergent use of the novel antiviral remdesivir. You can read about that and all of your COVID news at mdh.com. We mentioned that because the episode this week, episode 69, deals in COVID a little bit, and not necessarily with anything to do with the disease or the virus, but a specific set of recommendations for patients in the era of COVID and what's sort of new in a specific type of cancer. And that has to do with a diagnosis that we were talking before the show started, used to be quite a bad bit of news to receive, but things are really moving in the right direction. And that's kidney cancer, GU cancer. And our guest today will be discussing sort of all of that, and then, recommendations in the era of COVID.
Well, physicians and oncologists of a certain age like me remember when kidney cancer metastatic was simply a death sentence. We took the kidney out sometimes because it helped the bone mets, and that's still a theme which makes its way into treatment algorithms today. But we now must have 10 medications. They're all VEGF or HIF-alpha directed, and it's actually difficult, and we talk about that with Dr. Lalani, about how to cycle in first line, second line, third line, depending on particular characteristics of the patient or the COVID era. And that was our theme. How are you treating, would you like to, and how are you treating with COVID? We talk about pills versus shots to keep patients out of the clinic in our kidney cancer. He did the same thing with bladder cancer, although the immunoantibodies do play a role there. Sometimes the marker, the PD-L1, is important, sometimes not quite as important. And prostate cancer, which, as we're aging and as men get to be a certain age, prostate cancer is a significant problem. I remembered with him a few ASCOs ago when there was enthusiasm to bring back the taxanes. We were doing hormone therapy, androgen therapy, and it turned out if you have about 4 bone metastases or more, significant amount of disease, the taxane made a big difference in your outcome and survival. Well, taxane brings you into the clinic, you have to get an injection, immunosuppressive. Perhaps in COVID area, he talks about how he might back off that theme a little bit.
Yeah, and that's obviously important and timely right now as we sit here in the second fiscal quarter of 2020. But it's also a nice thing to look back on, just because there's been so much movement in the past 5 years. So I hope you enjoy the interview. It's with Dr. Aly-Khan Lalani. He is from McMaster University, which, for those of you paying attention, that's in Canada. And we've got an interview coming up in the next couple episodes, if you're listening as these episodes drop, with someone from Latin America. So we're going all over the Western Hemisphere, which is pretty exciting for blood and cancer. But we're going to continue on with Dr. Lalani Yurkowitz. She is dealing with other matters, of course, as many of us are. So we decided to reissue some back episodes of Clinical Correlation because she's done such a great job, and the show keeps growing and growing and growing, and many subscribers will not have heard some of her older Clinical Correlations. This one I thought was poignant just because of the history of GU cancer. It's what to do and how the conversation goes when there's no more curative options left, no more stage 4 or Mets chemo or immunotherapy, and how important that conversation is, but how, pardon me, but how important it is to be honest and truthful, but aware of your surroundings as well.
Yeah. And so I really enjoy her pieces. I think we might title as we go forward the next few weeks, The Best of Ilana.
Yeah.
And this was certainly in those top 10, where you're out of options that are curative, and you have to somehow have this discussion with the patient, which can be such a downer for the patient, family, and you, that they're coming to realize, I may not beat this. And so you never want to extinguish hope altogether, if at all possible, but you don't want to be honest and just be Cinderella all the time. So she tiptoes through that discussion very nicely.
Yeah, absolutely. So we'll keep you up to date with Dr. Lalani Yurkowitz, Clinical Correlation, The Best of, and stay tuned for our interview with Dr. Aly-Khan Lalani, all about GU cancer in the era of COVID. Dr. Henry, thanks so much for joining me tonight.
Thank you, Nick. Thanks so much.
I'm your host, Dr. David Henry, and you are listening to Blood and Cancer on iTunes or wherever you get your podcasts from. And we're also online, mdedge.com/hematology-oncology, where you can read about what's happening in COVID or what's happening in oncology as we try and keep practicing oncology through this epidemic. And I'm delighted today to be going north of the border up to just outside Toronto, talking to Dr. Aly-Khan Lalani, who is an assistant professor of medicine at McMaster and a GU medical oncologist specialist. Dr. Lalani, thanks for taking the time to join us.
David, it's a pleasure. Thank you for having me.
Well, you're very welcome, and I was so impressed. It must be your Canadian flair that the article we're going to click through that you authored is published in May, and as we record this, it's April, so we're really ahead of ourselves. Of course, it's on a preprint electronically online. It's going to air in the Canadian Urological Association Journal, and it's titled Prioritizing Systemic Therapies for Genitourinary Malignancies, Canadian Recommendations During the COVID-19 Epidemic or Pandemic. And as we've been doing a lot with our weekly podcasts and speaking with oncologists, medical, surgical, radiation therapy, how are you doing what you do, and how does COVID-19 change that? So what I thought we might do, we're recording this toward the end of April, and here in Philadelphia, I think we've hit the plateau. We are in the shadow of New York, and we're nowhere near as bad as they are, but certainly very busy. And I think you and I were discussing it's certainly there. And do you think you've reached your peak yet with COVID?
Yeah, I would say so. Just for the listeners, Canada, a country of about, let's say, 37 million people. The largest state or province is Ontario, where I am at, and we saw some good modeling data this week. Again, the week of April. Now we're at 24th today, but I would agree with you, David. We probably prepared, I think appropriately so, for a big surge. And thus far, we've seen, at least from hospitalization and ICU use, has really kind of at least plateaued as far as we can tell this week, operating in potentially a more favorable or so-called best-case scenario. So at least for now, from the acute side of things, I think I would agree with you. We've reached our peak and potentially plateauing.
Well, that would certainly be nice. And also, as we record April 24, as you said, we've stopped prescribing hydroxychloroquine. We think the data now, and I think this is national, and recommendations from NIH and CDC, that it doesn't work. And we're not going to use disinfectants, as may have been suggested by some out of Washington, to take care of the disease either. So we're still working for therapy, and I'm a hematologist oncologist, and we're fascinated by this clotting phenomenon, which is still under investigation. And I'll mention that I've just learned there's an up-to-date update coming out very soon, in a chapter on coagulation and COVID-19. But let's then get on to,
Excellent.
Yeah, it should be really interesting. So for GU oncology, this wonderful piece you authored is, I thought we'd click through three of the cancers which we see all the time as medical oncologists: prostate cancer, urothelial/bladder cancer comes to my mind, and renal cell. And so I'm just going to pick a few places, and you can elaborate as much as you would like on my questions. So the first is treatment for metastatic hormone-sensitive disease. We're talking prostate cancer now, metastatic. And I remember so well A few years back at ASCO, when we all thought, gee, hormone therapy, who would give these men chemotherapy? And then docetaxel came out, it might have been plenary, saying, well, this is life prolonging, and I believe the men have to have at least 4 or more, they have to have a fair amount of bony disease. So I think in your piece, because that brings patients in, there's myelosuppression, how are you handling those men now, given that data? Have I quoted it correctly, and how are you handling them then or now?
Absolutely, David. I was a trainee at the time, and the short story beyond that is I remember watching that plenary, and a few years later, when I became a fellow at Dana-Farber, Chris Sweeney, who was first author, was someone I was just sitting outside the office for connecting with. So it was a full circle for me. But absolutely, the metastatic hormone-sensitive space has evolved in the last handful of years. Focusing on the COVID landscape, I think, we certainly know that docetaxel has a survival benefit. You've rightly quoted the STAMPEDE trial. There is some recent data out of the UK for STAMPEDE kind of showing the benefit of docetaxel regardless of your, let's say, bony metastatic disease. But I do think that in this era, we gave some serious thought as to what do we do in the landscape that now includes androgen receptor axis target therapies, or ARATs, as I'll call them.
Yeah.
And so we do have data for these oral therapies in addition to androgen deprivation therapy by your hormone injections. And so when you look at these men, again, metastatic hormone sensitive or really hormone naive disease, when deciding between a variety of these oral pills or IV docetaxel chemotherapy, the latter being, well-known, cheap, 6 cycles and done, as opposed to oral pills indefinitely, the feeling was that in a COVID climate that it, really given the frequent resource utilization and the risk of toxicity, as you've mentioned, particularly neutropenia, that might be something we would defer away from and instead elect for oral pills where we might have a conversation about both chemo and oral ARATs. Instead, we would prefer oral targeted therapy in this patient population. I think that's something that has been really endorsed widely in North America and Europe. So I think we're very in line with that. The feeling is that this is added therapy to the hormone injection, so that becomes the base for these patients, and that it might be reasonable to wait up to 6 months from the first hormone injection to add this oral ARAT targeted therapy. And this is really available now regardless of your risk group. And so we thought that was a very fair recommendation for this popular disease.
So to be sure I understand, so you might, knowing about the data, nevertheless, docetaxel brings them in, and if they get myelosuppression, you would then do one hormone shot that will give the large hormone shot for 6 months, and then see how that does, and then do the oral after that.
Yeah, absolutely. So the hormone injections, other LHRH agonists in general, there's also antagonists that can be given in a more frequent monthly interval. But certainly if these are Q3, Q4, or even Q6 month injections, the point really being that a patient can at least get one of a, let's say, a Q3 monthly injection, and then at the time for their next one, begin this conversation, and especially given how much changes week to week, waiting an extra month or two or having that extra time to really think about this adds greater clarity. So we felt there was no rush to start the hormone injection and the oral pill up front. In fact, give the patient some time. The PSA should decline, and so long as there hasn't been a quick hormone resistance or castration resistance, the feeling is that we could delay the addition of that oral pill up to 6 months, and we have some clinical trial data that would support that.
All right, and so that also brings to mind, especially with the bone-only disease, which most men will have, and having bone pain. You mentioned radium-223, which sadly I haven't used in a long time. So 2 questions: should I be using that more, and should we be following? I think there's an international recommendation by ASCO that bone met from whatever cause, solid tumors, should have a bone agent like zoledronic acid or denosumab. So maybe comment on the radium-223 and then an active bone agent to prevent SRE, skeletal-related events.
Yeah, 2 really good questions. So from the general systemic approach to, for example, the hormone resistance setting, which we're now transitioning to, again, there's a few points there. One is to say that perhaps where a patient has not had any prior therapy, an oral ARAT, as we've talked about, would be a reasonable first line. But as you're starting to point out, that what about in patients who have progressed on, let's say, an ARAT or an oral therapy, and now are looking at a next agent, and where we might consider chemotherapy, but if we are in an evolving or volatile COVID pandemic, what do we do next? And so really, in a bone-only disease patient, I think it's very fair to consider radium-223. We have really seen an uninterruption of both the production of the radiopharmaceutical and the availability to administer that at our center. And when you consider radium administration, injections, and resource utilization versus potentially Q3 weekly taxane-based chemotherapy, the feeling was that if a patient is eligible for radium, that might be a more preferential agent in this setting. And it's, I think, further supported by the fact that, as you said, the eligibility really is in patients who have bone-only disease, and using that in general earlier on in the CRPC setting, really irrespective of COVID, is probably the right thing to do, because that may not be an option later on. So from the radium piece, we wanted to make sure we included that as an alternative to chemotherapy in eligible patients. Now, the second point you made about skeletal-related adverse events, or SREs, again, the utility of zoledronic acid versus denosumab, I think, is a very important consideration of these prostate cancer men as you try to administer as much standard of care as possible. But I think using denosumab was felt that in the priority list of agents, as you start to think about your toolbox during COVID, perhaps is a bit lower down just in terms of the magnitude of benefit in these men. But if it's accessible, for example, through home injection programs, if your region allows that, at our center, we have our pharmacy department able to administer denosumab without needing an in-clinic visit. And obviously, when you consider how zoledronic acid will be administered, having an outpatient delivery of denosumab was felt to be more favorable. So if those logistical availabilities are there, again, around the theme of potential assessment of resource utilization, then we felt that was reasonable to do. But if it needed to be held off in an escalating pandemic, we felt it was very fair to hold off on those types of treatments until we got some more clarity. And again, reassuringly, I think in the center you're at and where I'm at, we're starting to see some leveling off. Yeah,
so awfully good points and answers. Just to leave this, to get it straight in my mind, the perfect ideal radium-223 patient be the man with significant bony disease and pain. Is that your perfect patient for that treatment?
Yeah, and again, I think relatively, now that symptomatic piece, certainly if someone has significant symptoms, that may be a caution for radium, but certainly in the good performance status, mild to moderate symptoms, and again, bone-only disease, very critically, I think that's certainly a good option when you're comparing radium and considering chemotherapy, kind of what is next. But if you have not used an oral targeted therapy like an ARAT, then certainly that would be our preference above all when you think about the administration of an oral agent that can be shipped to home and can have telemedicine follow-up as opposed to radium or chemotherapy.
Okay. And then to leave the SRE preventers, skeletal-related events behind, just as you say, we're moving a lot to home infusion. The zoledronic acid, of course, is IV and I guess technically needs a creatinine check, and the denosumab, while more expensive, currently would be a sub-Q shot and could be given in the home easier. All right. So then I wanted to move to the second cancer, urothelial, and I think what comes to my mind is a metastatic bladder, typically transitional. And I believe the recommendation in the piece was platinum-based double chemotherapy up to a maximum 6 cycles, marginal benefit beyond 4. Now, of course, this violates your idea to try and keep the patients away from us and without IV therapy, but I guess this is such a good regimen that was still your first choice.
Yeah, no, and I think that's a very important point. So if we focus on urothelial carcinoma from an advanced or metastatic setting, as you said, the feeling is that these patients, this biology, as you know, is in the GU landscape quite unique, quite an aggressive biology. The expected survival for these men is very different than an early prostate cancer patient, even a prostate cancer patient who is metastatic. So these trajectories are different. The underlying biology is different. And so when we want to advocate for these patients, we would still feel that, using the platinum doublet here makes good sense, just because their competing risks of disease progression might outweigh the competing risk from COVID. But again, that's an evolving space. So the recommendation was still that these first-line regimens should be offered. Now, when we look at using cisplatin, or in cisplatin-ineligible patients, carboplatin plus gemcitabine, the feeling was that the myelosuppressive, aspect here, perhaps for 4 cycles, is not that significant, where we made a blanket recommendation for adding, for example, supportive treatment like G-CSF. Certainly, if a practitioner feels their patient will warrant it for a variety of reasons, then that could further help support them through. But the neutropenia rate from Gem-Cis was felt to be not that excessive, certainly not like the testicular cancer treatment. So we didn't make a recommendation outright for supportive G-CSF, but certainly that could be considered. And as you've said, we have this vague range of 4 to 6 cycles, but in a COVID situation, we felt the benefit beyond 4 was something that needed to be considered. So really 4 cycles of combination chemotherapy up front was a very reasonable recommendation for these patients who have, or potentially could have, very aggressive biology.
And have a very good response if they respond. And that takes me to the second point, which is for platinum refractory, or maybe second line, the checkpoint inhibitors, immunotherapies. So maybe speak to that. Who's the perfect patient for that? What's your regimen? And is PD-L1 or tumor burden status important?
So the feeling is that for these men who are safe and eligible for a next line treatment like a checkpoint inhibitor, in as much as we can, we would like to offer this and continue to offer this to our patients. Which agent, I think varies by jurisdiction. Certainly in Canada and most provinces, a PD-1 inhibitor like pembrolizumab, given its survival benefit in a phase 3 study, would be the go-to. But I know based on FDA approvals, other PD-1 or PD-L1 agents are certainly accessible throughout most jurisdictions. So the feeling was that these are generally well-tolerated agents. As of today, we don't know for sure that checkpoint inhibitors necessarily would affect how a patient experiences COVID or their natural response to COVID. So the feeling is that these are still safe monotherapy checkpoint inhibitors to use, though the general kind of safety measures, I think, are still reasonable. So if your patient would be eligible but can be safely delayed based on their CT scan, their clinical status, that might be very reasonable to do in a COVID climate. If they're already on a checkpoint inhibitor, there are potentially ways to consider longer dosing, interval dosing of a checkpoint inhibitor. So just one example, pembrolizumab is available in every 3-week dosing, flat dosing of 200 milligrams. But there is availability to access that every 6 weeks with 400 milligrams. And so that may be a way, again, to reduce resource utilization. So both the initiation of checkpoint inhibitor, the timing of that, and then, the interval between dosing is something that can be discussed, but we certainly wanted to advocate that our patients should still have access to this life-prolonging therapy.
Well, very points well taken, and we're gaining more and more experience with the checkpoint inhibitors and more tumors. So I have used it in this setting, and it's when it works, it's terrific. And so we're getting PD-L1 and checking and tumor mutation burden all the time. So that moves us on to renal cell carcinoma, and I just marvel as I get to this cancer because in my career there used to be nothing, and now I have to quickly go to NCCN to click through the preferred and the first and the second line because there's 10 different choices. And so let's, in your piece you mentioned the good risk and maybe the intermediate to poor risk. So think in your mind, first of all, the metastatic renal cell, and you're considering first-line therapy and the good risk. Could you define good risk, and what would be your first choice therapy here?
Yeah, you're absolutely right. First of all, David, the evolution of kidney cancer has been so exciting. As someone junior like myself, I think it's been great to go through this at this time of my career. And I think everyone's excited, but as you said, there are a variety of options available. And we tried to distill it very clearly and hopefully pragmatically for the readers. Firstly, the IMDC criteria is what we're using to risk stratify our patients, at least in terms of prognostic criteria. So in a patient that's good risk means they have 0 of those risk factors. So when we look at clinical lab values or their performance status, these 6 factors, if there's none of those, then that would be considered a good risk patient. And so historically, single agent VEGF TKI like sunitinib or pazopanib were very standard first-line agents. But more recently, we have seen through the Keynote 426 study for those who treat kidney cancer, we know that there's now an overall survival benefit by adding, for example, a PD-1 checkpoint inhibitor plus a VEGF targeted therapy versus a VEGF targeted therapy alone. So that is our standard of care. We wanted to advocate that standard of care, but a few considerations. First, we do know that active surveillance in these good risk patients with a relatively low burden of disease is a well understood potential treatment option. And so our patients should always be assessed if active surveillance is possible. And if that's not possible, then the feeling was that we should endeavor to give combination upfront therapy as much as possible. However, in a COVID pandemic, we were concerned that jurisdictions and different countries at the time and continents really might have a different COVID experience. And so resource utilization for IV treatment for cancer and beyond, potential hospital constraints to manage your immune-related adverse events led us to at least recommend that patients should at minimum have an oral VEGF targeted therapy as part of their systemic treatment. And with more COVID clarity, then perhaps the intravenous portion of the checkpoint inhibitor could be added later. I think that certainly was the approach in most places in the United States and in the UK. And so I think we felt that that was very reasonable to do. But again, the caution here, David, is that as COVID provides some clarity, depending on your jurisdiction, we did want to advocate for patients to have the checkpoint inhibitor then added subsequently. So not to leave a patient on historic standard of care, but to build upon that as you got perhaps some flattening of the curve, so to speak.
Well, it makes perfect sense. So ideally you would, and again, if in a heavy COVID busy area, we would do oral first, and then if things settle down a bit, you could fold in, keeping the oral, fold in the checkpoint inhibitor with it. So then,
absolutely.
Then moving on to the intermediate to poor risk, I guess I'm picturing here by your definition someone with a higher burden of disease, maybe an LDH, maybe a calcium, anemia, these other factors. You're really more worried now. And so now how would you approach that intermediate to poor risk patient first line?
Yeah, and as you said, it's become a very crowded landscape. So for patients who have intermediate risk disease, these patients have 1 to 2 of the criteria we've talked about, or poor risk would be considered 3 or more. So really in this group, which we've lumped together, intermediate to poor, basically by definition, they have at least one of these factors or more. Now, the current standard of care would be that these patients have a choice and have options between combination checkpoint inhibition like PD-1 and CTLA-4 directed therapy, or combination PD-1 or PD-L1 and VEGF targeted therapy. So again, a pure IV, pure immunotherapy combination, or IV checkpoint inhibitor plus oral VEGF targeted therapy. So how do we help guide practitioners or our regions and institutions on what we do? And the feeling was that both of these options, again, this is significant life-prolonging therapy. These are first-line treatments in these patients. We should be advocating for use here. But with the presumption, and again, it's still to be defined in the COVID era, but with the presumption that PD-1 and CTLA-4, so for example, nivolumab and ipilimumab, might have more immune-related adverse events,
Indeed,
which might necessitate hospital admission and might lead to more prolonged use of corticosteroids, that perhaps choosing a regimen, an alternate regimen like PD-1 plus VEGF target therapy might make more sense in an escalating pandemic. So it's not that PD-1 plus CTLA-4, at least to our knowledge today, necessarily makes you more prone for COVID, but you're asking for potentially more IRAE, more admission, and more steroid use. So the feeling was that if systemic treatment was needed in these patients, to defer perhaps to a PD-1/PD-L1 plus VEGF targeted therapy regimen.
Yeah, I couldn't agree more. Many of our patients, even in remission, our cancer patients across all tumor types, are saying, can I get it easier? And I'm mostly answering them, no, but your ability to fight, and as you point out, especially given dual immune therapy, you might be impaired, and of course adding steroids, so your ability to fight might be worse or more difficult.
Right.
So I think we've covered those 3 therapies very nicely, through tumor types with their therapies very nicely. And I want to thank you for joining us today on the Blood and Cancer Podcast. And I want to remind our listeners that you've been listening to Dr. Aly-Khan Lalani, who is an assistant professor of medicine at McMaster University, a GU medical oncologist specialist, and he's been a super help to us today in this COVID era. And Aly-Khan, I thank you very much for taking the time to join us.
David, it's been a pleasure. Thank you for having me.
And that concludes the interview portion of our show this week. This is episode 69 of Blood and Cancer. Blood and Cancer will be right back with the best of clinical correlation right after this. Welcome back to episode 69 of Blood and Cancer, the official podcast of MDH Hematology-Oncology. It's time now for Clinical Correlation, the best of Dr. Lalani Yurkowitz.
I'm Lalani Yurkowitz, and this is Clinical Correlation, a segment about the human side of hematology and oncology care. I'm going to get a bit on my soapbox today and talk about a statement I've heard many times from well-meaning, often less experienced providers, but sometimes also experienced providers. It comes up during a critical transition when we no longer have chemotherapy or immunotherapy options for a patient with advanced cancer, and the goal is to discuss palliative care and/or hospice. The statement that I've heard so many times goes something like this: "I'm sorry, but we don't have any more treatment to offer." This is problematic. It's problematic not just because it can signal abandonment, suggesting to a patient that their own doctor is giving up on them, but also because it's not true. Those who use that statement are really saying we don't have any more cancer-fighting treatment to offer. But we do have treatment. Palliative care is treatment. It is standard medical care focused on symptoms and quality of life. It's medications for pain, for nausea, for shortness of breath, and it's a philosophy that can be compatible with cancer-fighting treatment, or a choice that we make when we no longer want to use or have cancer-fighting treatment available. And there's data even that a palliative approach to therapy can improve not just quality of life, but even lifespan. I'm hoping we as a medical community and educators can retire that phrase, and with it the school of thought that says if we're not giving chemo, we're no longer treating the patient. I'll end with a brief anecdote that I think captures exactly why this statement can be so problematic. After a well-meaning resident used the phrase with a patient with advanced cancer, she asked with astonishment, "So no more oxycodone for my bone pain? No more Zofran when I'm throwing up?" And of course, the resident was quick to correct and reassure her that no, of course, we would still be offering all of those things. Of course, treatment takes forms outside of chemotherapy or immunotherapy. Of course. Thanks for listening, and I hope you'll tune in next week for Clinical Correlation.
And that's a wrap on episode 69 of Blood and Cancer. Let's get to this week's credits. Blood and Cancer is hosted and produced by the editor-in-chief of MDH Hematology-Oncology, Dr. David Henry. The Clinical Correlation segment is written, recorded, and produced by Dr. Lalani Yurkowitz. Blood and Cancer is produced by MDH editor Jennifer Smith. All MDH podcasts are produced by MDH and Medscape editor-in-chief Dr. Ivan Aransky, along with MDH executive editors Mary Ellen Schneider and Kathy Skarbeck, and multimedia editor Terry Rudd. Social media is produced and posted by Kyla Clark. I'm your audio editor, audio engineer, and the voice of MDH podcasts, Nick Andrews.